Hello, my name's Joe Scott-Jones. I'm a GP in Apotiki, Chair of the Rural Health Alliance and Chair of the Rural Chapter of the New Zealand College of General Practitioners. And I'm here on the couch with Anne Hendry, Clinical Lead for Integrated Care from NHS Scotland and a geriatrician in Hamilton at the college conference. Hello, Anne. Tell us a little bit about yourself.
Thanks very much. I'm delighted to be here and take part in the conference in Hamilton. My clinical background is a geriatrician and stroke physician, but probably for the last 5-6 years I've been working nationally across Scotland supporting the Reshaping Care for Older People programme, and then that's gradually evolved into integrated care for all adults,
right,
with a particular focus on supporting people with complex care needs. So that's adults with multiple long-term conditions, combination of physical and mental health problems,
yeah,
and looking at how we might use technology to enable that integrated care and support.
Just what do we mean by integrated care? Can you?
Yeah, I suppose that's to use that phrase, joined up care that is coordinated, and care that connects health and social care support, yep, along with the support from the third sector, as we call it in Scotland, or you would describe it as your NGOs,
yep,
and also care that is focused on place, focused on that local community and the contribution that the local community might also provide to the care and support.
So the integration is across the
health social care, housing, with the third sector and also some of the independent providers. And we're also very much conscious of health needing to be integrated across primary care, hospital care, mental health.
Yeah. Mm-hmm. And is there much evidence that integrating care like that has a significant impact on the standard of care, on the outcomes that patients have?
Certainly, in terms of the personal outcomes for people, improving lives, improving quality of care and experience, there's good evidence. There's probably less compelling evidence that it saves money.
No.
And so that's really important, because we're not doing this to drive cost efficiency. This is really about improving outcomes for people. And it's also a better experience for staff as well.
Yes.
You know, when you're working in a much more interdisciplinary team that's coordinated.
Yeah. We often reflect in New Zealand that those small communities that are maybe geographically isolated, partly out of necessity, but also out of just the lack of ability to provide care from outside, have a more naturally integrated approach to the way that they deal with care. The other movement that you'll be aware of here in New Zealand is the whānau ora movement from supporting putting a great deal of emphasis on the social determinants of health and trying to provide health navigators to support people through their healthcare journey as well.
I was reflecting on that, listening to the session on equity, because while we perhaps don't have the same cultural issues, we certainly have the socioeconomic deprivation issues that, you know, there's clearly a health inequality challenge in Scotland that we have to tackle. So looking at how we might have a focus on place and local community and use some of the community assets differently to amplify the kind of support around a general practice. So health connectors or community connectors are some of the models of care that are what we call our deep end practices.
Yes,
our
deep end, yes.
Deep end are 100 most deprived general practices, or I should say the 100 general practices in the most deprived communities are exploring some of those models of care.
So is the integration focused on the general practice as the patient's first port of call, and then you're bringing the care into the general practice, or under the linking through the general practice to those levels of care?
I suppose, if I was being honest, I would say that we're focusing on a locality or a local community as being the integrator, but obviously primary care is at the heart of the delivery of health care within that locality. both health, social care and some of the community supports are wrapped around the health, the primary care practice. So some of the models that we're trying to develop is seeing perhaps the house of care model, the year of care as it's known in the north of England, is seeing how the practice might be at the heart of a wraparound model of community supports and some of the wider extended primary care team, the pharmacist, the district nurse, the allied health professional, and also secondary care clinicians being part of that. That's a new and exciting challenge to attract secondary care professionals into community.
Yes.
As a geriatrician, I've always been community facing, but it's only in more recent years that some of my colleagues are now actually basing themselves in the community, instead of being based in hospital.
Really? So tell me about the information technology and how that is being utilised in Scotland to aid the integration of care.
We're describing the technology as being an enabler. In a sense, it's potentially really quite a disruptive innovator, a real catalyst, a real game changer if we get the use of technology right. We've been on a journey with the use of technology. We've had probably about 8 years ago, we launched a technology programme around telecare, and that was particularly adopted by our local government, our local authorities, in terms of providing the sort of assisted living technologies in the community. And we more recently converged that telecare programme with our telehealth programme, which was looking at some of the simple home health monitoring for COPD or heart failure, as well as some of the video conferencing facilities to provide remote decision support. And so more recently we now have a more sort of comprehensive telehealth care programme, and we're currently aligning that better with our e-health programme, because there's a clear interdependency between all of that.
So just clarify for me, and I think sometimes it's our use of language, even within New Zealand, we talk about e-health and m-health and telehealth and telecare. Is there a common language around all of this? Do when you say telehealth, do people who are involved in this know exactly what you mean internationally, or does it mean different things in Scotland and in New Zealand?
I think telehealth refers to the sort of video consultation or the home health monitoring kit. Telecare is much more about the practical supports that people might need to take part in normal activities of daily living, like the community alarms, the flood fire sensors, the wandering monitors, things like that.
Okay. And Scotland, like New Zealand, has huge distances and very remote and island communities. How on earth do they manage with integrating telemedicine when, I mean, presumably you have the same sort of problems with broadband access that we have here, or internet access here? Yeah,
and the broadband coverage is an issue. I mean, that's been referred to several times over the conference here, and it's similarly an issue at home. At a strategic level, we've got a digital strategy which has been aligned with our telehealth care strategy, so that we've got cross-government support for the rollout of broadband coverage in Scotland. Still got a bit to go, but there's a clear plan in terms of that rollout. We're also exploring some more creative options, like looking at the use of some satellite systems in some of our areas. But we've certainly got capability beyond what we've tapped into so far. So there's certainly room for more spread yet.
So there's activity around home monitoring and improving the connection between the patient and the provider, through general practice and also through the hospital-based outreach nursing services and outreach specialist services. And then there are links between community providers and hospital specialists through the telehealth supported networks from practice into hospital, and that I would imagine is providing education and also direct patient care with the GP or nurse alongside the patient. What about emergency services and telemedicine? Is there a...
We've got, particularly in the northeast of Scotland, in the Grampian area and covering some of the island boards, we've got an unscheduled care network which is providing some of the emergency response, so connecting perhaps an island community with an A&E consultant on the mainland who's able to look at some of the X-ray imaging that's being done and, you know, give some advice or reassurance or professional decision support to say, no, this needs to be transferred. And that's now really quite mature in terms of people's understanding of how it works, people's confidence in how it works, and patient and carers really quite confident and reassured in using it. The other way that connects is with some of the community hospitals on the mainland that are at some considerable distance from the District General can use the video conferencing and transfer of imaging to save a round trip of maybe a couple of 100 miles.
Yes.
And we know that that's not a good thing for older people to have to sort of transfer that distance.
Yeah. I met with a researcher, Philip Wilson, who was from the UK, and he was looking at in the Highlands and Islands using an ultrasound scanning device to diagnose stroke. His research project was sponsored by NASA, who were providing the satellite to link the data, which I thought, wow, that was he was applying, I think, for the funding. I'm not sure whether he got it or not, but there's such a huge capacity, and you know the. Did you think as a geriatrician that you would?
Telestroke's a really good example of where that's working well.
Tell us about telestroke.
Telestroke, as well as a geriatrician, my subspecialty interest was stroke, and for a number of years we've been working across Scotland in developing stroke services, but also, you know, trying to look at the rollout of thrombolysis.
Yes.
And so we have CT imaging capacity on island, but we don't perhaps have a stroke clinician on island who's able to respond out of hours to an emergency. So we've got a network established that somebody can be CT'd and then the image transferred, and a stroke consultant on mainland will be able to look at the CT and again make the diagnosis about whether or not the person's appropriate for thrombolysis.
So do you have a standard of care around how long it takes to access the CT scan for rural populations?
Yeah, we've got, not all of our rural populations will be covered by CT imaging access in the time window for stroke CT. But in some areas of I'm thinking the Western Isles on Stornoway, for example, there's a sizable population who has got really good CT access, but they don't have a stroke clinician access. But we can get round that.
Yeah, it's fascinating. Did you think as a geriatrician that you would be becoming so knowledgeable and focused on information technology when you started off?
Definitely not. Definitely not. Probably the least digitally aware as a trainee, but I think the thing that I've been struck by is it's not just a rural agenda.
Yes.
My clinical practice as a geriatrician was in an urban setting, but the patients don't travel well. The population of patients who are complex dependent and at high risk of delirium if you move them. So there's something for me about we need to make more use of the technology even in an urban setting. Some of our examples of video conferencing into care homes.
Yes.
We've explored that in Highland remote communities and done sort of perhaps community psychiatric support at a distance to the care home to help manage antipsychotic prescribing, reduce benzodiazepine use, and give advice to the care home in managing people with complex behaviour support issues. Now, that's a fantastic resource, and there's no reason why we can't also use that in the cities where often CPN capacity is quite tight.
Yes. Yeah, absolutely.
So it's about making best use of the skill mix that you have.
Yeah. And I think in any deprived community there are going to be issues around access. The issues, obviously rural communities about distance is one of the issues, which isn't perhaps the same in an urban centre, but you still have the same issues around motivation and affordability, and familiarity and cultural difference of moving from your GP practice that you're familiar with, or into a hospital setting to see a strange person who comes often from a different culture. Absolutely, telehealth and telemedicine I can see as a great tool for breaking down all those barriers of access. I think
there's really good examples of where health literacy has been, part of the system development. So if I think of examples of people with learning disability who have helped in the design of some of the telehealth equipment that they would be using, and got really, with the sort of development of some of the innovations, some of the apps nowadays, we can get some very, very intuitive designs that are very easy for people with cognitive impairment, with visual impairment to use.
So you were of the Gartner scale or curve of technology, and where would you say that you are on the Gartner curve? Are you in the peak of expectation, or are you in the trough of experience, or are you climbing out of the trough into a sort of more of an effective longer term?
I think we've gone beyond the peak of excitement.
Right.
We've probably dipped a little in that you realise that the enormity of the challenge of spread, but we're coming back up because we've been able to, which is fantastic news, we've been able to leverage some additional funding to support scaling up.
Yes.
We've got £10 million for the next 3 financial years, which is going to go quite far in terms of supporting adoption of probably, if we focus on a few things that we know that there's good enough evidence and we just need to spread them. So we're focusing on more of the video consultations and using that beyond health, so looking at, health into care homes and other social care settings, looking at scaling up some of the simple home health monitoring, not very complex kit, but some of the light touch monitoring that uses available day-to-day technology for SMS messaging and symptom control feedback. And then finally looking at probably some further adoption and spread of the telecare equipment, recognising that there's now good evidence that is delaying, if not completely preventing, institutionalisation. We've got some decent studies from some of our health economic colleagues that have worked with 1 or 2 of our partnerships to look at the cost avoidance of telecare in a dementia population.
Right. So your understanding of the New Zealand telehealth situation as a whole, where would you think? And it's always very hard to say this but it's useful to have an outside perspective on how we're doing. Where would you say we were?
Again, I think you've got lots of. My sense is that you've got lots of enthusiasts and that you've got quite a number of tests and pilots, but perhaps not quite got to the systemising of it.
Yeah.
And certainly our learning has been that the redesign of the system is as important, if not more important, than the actual implementation of the technology.
Right.
So it's all very well having wonderful telehealth equipment, but unless you've redesigned the way processes around that are implemented, then you'll not maximise the outcomes.
Yeah. So one of the key things was aligning the digital strategy with the health strategy and what you're trying to, and the impact of telehealth.
Yes, but also not just at the strategic level, also at a very operational level, that introducing home health monitoring for COPD in a locality isn't going to make a difference in emergency admissions unless you're connecting that with the front door processes and what happens when people call an ambulance.
Yeah. Yeah.
So joining up the pathway, embedding the technology within the pathway.
So just finally, if you had a few words of advice to give the National Health IT Board and the people that have control over our digital strategy and implementation of technology into to help integrate care in New Zealand, what pearls would you cast before us?
I think I would say it's a long game,
Yep.
so don't expect instant results, but there's now compelling evidence from across the globe that technology gives greater choice, control, it empowers individuals, and if we're really trying to build resilience in individuals and in our systems, we must do this.
Yeah, we must do it. It's an inevitable thing, really.
Absolutely.
Thank you very much, Anne, and thank
Pleasure.
you for coming all this way. It's a long way to come. So,
Pleasure.
Thank you.
Thanks.